All right, welcome to the deep dive. Today, we've got a fascinating topic lined up, and it's specifically for you, our listener, the learner. You sent in this really interesting entry from the Stanford Encyclopedia of Philosophy on the philosophy of medicine.
And we're going to unpack it together. So think of this as a sort of guided exploration into the core ideas behind health, disease, and medical practice itself.
From a philosophical perspective, right?
Precisely. It's really a deep dive into the theory, the conceptual foundations of what medicine is and how it works.
Yeah. And this entry gets into some pretty heavy philosophical stuff, the learner,
Right.
like metaphysics and epistemology, basically the nature of reality when it comes to health and disease and how we can even know what's true in medicine.
Exactly. We're talking about debates that have been going on for centuries, really shaping how we think about medicine in the Western tradition.
And what's so cool about this, the learner, is that even if you're not, a philosophy expert, the questions this entry raises are things we all grapple with. I mean, we all have bodies, we all get sick, right? So we're going to be talking about concepts you might think are simple, but when you really dig in, they get complicated fast. Like, what is health, actually?
Yeah.
Where's the line between just feeling a little under the weather and having a full-blown disease?
And why are some conditions, some diagnoses so controversial?
Yeah, exactly. Yeah. And how much can we really trust medical evidence? What role does judgment, expert opinion play in all of this?
Great questions.
All right, let's jump in.
Let's do it.
So first up, the entry tackles this really fundamental question. How should we even define health and disease?
It seems obvious, right? But this has actually been a huge point of debate in the philosophy of medicine for a long time.
Yeah, you go to the doctor when you're sick. They try to make you healthy.
Yes, yeah. But then you think about situations like pregnancy. Clearly not a disease. It's a normal biological process. Or someone with high blood pressure who feels perfectly fine.
Totally. So where's the line? The source really emphasizes this inherent vagueness, this fuzziness in how we separate health from disease.
And it gets even more complicated. Because one philosopher, Engelhardt, points out that it's not just about describing a biological state. There's also this evaluative aspect, this judgment built in. He says that the concept of disease acts not only to describe and explain, but also to enjoin to action.
Meaning?
Meaning it tells us what we should do. It indicates a state of affairs as undesirable and to be overcome.
So how we define health and disease has real-world implications.
Yeah.
It affects when people seek treatment.
And how society views them.
Right. It's not just about biology, it's about values too. Now, the entry also touches on this tricky thing about how we use disease and illness almost interchangeably.
But there is a subtle distinction. Disease often refers to something more objective, a specific pathology. A literal lack of ease.
Caused by, internal malfunctions, external factors, or some combination.
Right, like a virus or broken bone. Illness, on the other hand, is more about the subjective experience.
Feelings, discomfort, changes in behavior, things a particular culture might consider undesirable, and that might lead someone to seek help.
Exactly. And then there's sickness, which brings in the social dimension, how society values or devalues different states of being unwell.
The entry mentions Parsons' concept of the sick role.
Right, where someone who's sick gets a pass, so to speak. They're temporarily excused from certain obligations.
And they're not blamed for their condition. So the learner, all of this just goes to show that being unwell isn't just a simple biological fact. It has personal and social layers too. Now, the source then goes on to explore some different philosophical perspectives on how to define health and disease, starting with what's called the naturalist viewpoint.
A key figure here is a philosopher named Bourse.
Okay, so for the naturalist, it's all about biology. Health is simply the absence of disease. And disease is an internal state that messes with normal biological functioning.
And they try to define normal in a statistical way.
By looking at what's typical within a reference group.
Exactly. People of a similar age, sex, that sort of thing. And how well they're functioning in terms of survival and reproduction. They even include environmental factors like getting cavities.
Interesting. So for them, it's all about how the body's supposed to work based on this biological blueprint. But this perspective gets some pushback, right?
Oh, absolutely. One big criticism is that it seems to ignore the role of values in how we define health and disease.
The source uses examples like masturbation, which used to be considered a medical disorder, or homosexuality, which was listed in the DSM.
And the reason those classifications changed wasn't because of new biological discoveries.
It was because of shifts in societal values.
Exactly. Now, the naturalists might argue that those were just mistakes, not real diseases to begin with. But the criticisms go deeper than that. Even when naturalists try to be purely biological, they're still relying on ideas of statistical and theoretical normality, a natural state.
Which isn't necessarily something that biology just hands to us.
Right. What's normal for a species is a complex question, even within biology itself.
There's no one perfect set of genes that defines normal.
And our physiological models are often, idealized. They don't always reflect the messy reality.
And then there are situations that really challenge this idea of biological dysfunction as always being bad.
Yeah.
Like contraception.
Which intentionally alters normal reproductive function.
We don't call it a disease.
No. Or someone who manages a chronic condition really well with medication. They might function perfectly normally.
The entry mentions a philosopher named Cooper, who focuses on this idea of the disposition to malfunction. But even that runs into problems with things like controlled chronic diseases. And another philosopher, King Songa, questions whether we can even objectively define those reference groups in the first place.
All of which really undermines this notion of a purely objective biological definition of disease.
Which leads us to a different perspective, the normative or constructivist view.
Where values take center stage.
Okay, so if naturalists are all about biology, the normativists are saying that it's our values that really define health and disease.
It's about what we as a society consider normal and desirable. And any deviation from those norms is potentially seen as a disease.
They argue that this reflects how we actually use language, and it explains how our views on things like homosexuality can change over time.
As our values change. And it can also account for these culturally specific illnesses that exist in some places but not others.
But normativism has its own problems too, right?
Of course. For one thing, it struggles to explain conditions that we generally agree are bad, like severe alcoholism or morbid obesity, which we might not always classify as diseases.
And another issue is that it makes it hard to argue that past disease categories were wrong, like drapetomania, which was this supposed disease that caused enslaved people to run away.
Right. If disease is purely a social construct, then, well, it was considered a disease at the time, which feels very uncomfortable.
Definitely. So to try and bridge this gap, there are these hybrid theories, like the one proposed by Wakefield,
which try to combine elements of both naturalism and normativism. Wakefield argues that a condition should only be called a disease if it both causes harm or diminishes someone's well-being and results from some internal mechanism failing to do what it's supposed to do, to perform its natural function.
trying to kind of rule out purely social diseases.
Right. But even here, the concept of natural function can be loaded with values. And these hybrid theories have their critics too. Now, the learner, one thing the entry points out is that the concept of health itself hasn't gotten nearly as much philosophical attention as disease.
Interesting. We often just define health as the absence of disease, but that feels a bit thin, doesn't it?
It does. The World Health Organization, the WHO, has that famous definition, a state of complete physical, mental, and social well-being.
And not merely the absence of disease or infirmity. It's a very broad definition.
And kind of ambiguous. Does that mean the goal of medicine should be this total well-being?
Should medicine be involved in everything that affects our happiness? The entry mentions Cass, who has a more limited view. He says health is what medicine aims to restore.
Which would exclude things like cosmetic surgery.
Makes sense. And then you have definitions like Whitbeck's, which focuses on the capacities, both psychological and physiological, that let a person pursue a wide range of goals. It's not just about being disease-free.
Someone with a chronic condition might still be considered healthy in this sense.
Right. And Kangelhem, he has this really interesting take. He says we shouldn't just equate health with statistical normality, because normal can just mean what's common, not necessarily what's good or ideal.
He sees health as something that makes us more resilient, more adaptable, a biological luxury, he calls it.
And disease is a loss of that adaptability.
Which connects to ideas of preventative medicine and this more positive view of health, as Tiles points out.
And then you have Carell, who brings in the lived experience. He says health is ultimately about how you experience your body, even if you have a chronic illness. It's much more dynamic and personal. Then you have more extreme positions, like Schwartz, who says there's no coherent concept of disease at all.
Or Heslow, who says the whole health-disease distinction is basically irrelevant for most decisions.
Their point being that what really matters is whether a particular state is desirable or undesirable, not what we label it. Then there's this idea of malady, proposed by Clauser, Culver, and Gert.
Which is meant to be a broader term, encompassing all forms of illness, injury, dysfunction, anything that's wrong with a person.
But that brings us back to those objectivist problems we talked about earlier.
Yeah.
Finally, there's Ereshefsky, who has this different approach. He separates the description of a state, the pure facts about someone's body and mind, from our value judgments about that state.
Which can be really helpful when you're dealing with controversial conditions. It forces us to be explicit about what we value and what kinds of states we want to promote or prevent.
So in the end, the learner, the entry, makes it clear that this debate about how to define health and disease is still very much alive. Do we go with objective biological definitions, or do we include social and experiential dimensions?
And none of the current theories are perfect. They don't necessarily give us easy answers for how to actually practice medicine.
Which leads us to the next big area this entry explores, the really messy business of disease categories. How do we recognize, name, classify, and legitimize medical conditions?
Right. And this is where it gets really real.
It does. The source uses the example of chronic fatigue syndrome, CFS.
Where the main symptom is this overwhelming fatigue after even minimal exertion.
But people with CFS have all these other symptoms too, and the severity can vary a lot.
And it's been linked to other controversial syndromes like myalgic encephalitis and fibromyalgia.
And because there's no clear, easily identifiable cause,
no definitive biomarker or test.
It hasn't always been taken seriously by doctors.
Leading to this feeling of illegitimacy for patients.
Exactly. And this gets to a bigger point, the learner. When a condition doesn't have that clear objective marker, its validity can be questioned.
Which impacts diagnosis, treatment, and how society views those affected.
It shows how social factors can shape what we consider a real illness.
And then there's the whole realm of mental illness and this idea of mental health. The entry really highlights the moral weight that comes with labeling something a mental condition.
Throughout history, psychiatry has been tied up with social values, sometimes in really problematic ways.
Using mental illness to categorize behaviors that were seen as deviant or conditions that didn't have an obvious physical cause.
The entry also discusses the criticisms of the DSM, the Diagnostic and Statistical Manual of Mental Disorders.
That's the main classification system for mental illnesses.
Right, and people have pointed out concerns about politically motivated revisions, cultural and gender biases, and whether it's even reliable and valid.
And these are big issues because the DSM has a huge impact on diagnosis, treatment, and even access to healthcare.
Then there are these radical critiques, like the one from Zaz. He argued that mental diseases don't exist.
Because they don't have that demonstrable tissue damage.
He said it was more about control and judgment than actual illness, that we should talk about problems and living instead.
But as the entry notes, we are finding more physiological and genetic links to some psychiatric conditions.
Like the twin studies on schizophrenia.
Right. And Wakefield, he applies his functionalist framework to mental disorders, calling them harmful dysfunctions.
Trying to ground them in biology, in terms of evolutionary function.
But again, that idea of function can be subjective, and the practical implications are still debated.
So trying to categorize the human mind is a tough business.
It is, and that's partly why Engel proposed the biopsychosocial model, which tries to unify mental and physical illness by looking at biological, psychological, and social factors all together. It's a more holistic view.
The entry says that this model is pretty popular in medical education and practice.
But it hasn't had the same impact on basic research, which tends to be more reductionist, more focused on the biological level.
So, the learner. We've covered a lot of ground here, from the very definition of health and disease, to how we categorize illness, to the role of values and social factors. And these aren't just abstract ideas.
They have real consequences for how we understand ourselves, how we seek treatment, how our healthcare systems work.
The way we define health and disease really shapes lives, both individually and as a society. So here's a final thought for you to ponder, the learner. Given all this complexity, how do you think our definitions of health and disease will change in the future?
What unexpected conditions might become medicalized? What conditions might be challenged or even demedicalized?
It's fascinating to think about. Thanks for diving deep with us.